Dr. Nora Martinez. She will be my interviewee for this assignment. So let's begin. Good afternoon. Please introduce yourself.
My name is Dr. Nora Martinez, and I am a faculty member at South Texas College and also the assistant chair in the ADN program.
Okay. Now, please tell me when you decided to become a healthcare professional and how did you get to where you are now?
I think it began, from what I remember, I always went to health careers driven high school, Med High in the Valley, and after having gone through so much of that, I realized I didn't want to be in the medical profession. So I decided to do pre-law, and that summer before I graduated, my senior year, my younger sister, who was at that time 10 years old, became a diabetic, and my parents both had little to no education. My dad had like a third grade education from Mexico. My mom had a GED, and the care of my sister involved 3 times a day getting injections, 3 times a day checking her blood glucose. And so my parents didn't feel like they were going to be able to do that. So me being the oldest one and the one who went through some type of medical training, they never asked, but I felt compelled to stay. And so I ended up staying a year at that time I was UTPA, and a year turned into 2 years, and before you knew it, I was getting ready to start my junior year, and I hadn't picked a track. And one of my aunts, much older aunt, actually is like, why don't you apply to the nursing program? And I applied, and I never knew that apparently it was competitive to get in. So I got in on the first try, and that's how I started my nursing career, and I've never looked back. So.
Okay. You also have a master's right now, don't you? And
yes. So I graduated with my ADN in '97 from UTPA. At that time, the associates was at UTPA because South Texas Community College didn't have the faculty to hold the degree. Of course, we all know the associates belongs in the community college. So until they found the qualified faculty to bring it over to the college, it was at Pan Am. So I was the second to the last class to graduate from there. When I finished that program, I worked 4 years in labor and delivery medical, and then I decided I needed to go back. And I needed one more basic to be able to join the bachelor's program. Back then, the bachelor's was, you basically did the same thing that the traditional students did. There was no accelerated tracks, there was no online teaching, and so it was a really hard thing to do because I was working and the classes were during the day, and so I had to get days off for that. I had to go to clinical, so none of my experience counted. So it's like I felt like I was just a traditional nurse. Finished my bachelor's in 2001, and I immediately started at that time, the family nurse practitioner track. And again, I didn't know it was ever a competitive thing. I hear now from colleagues that there's over 300 people applying. When I applied, I got in, and it was not very known back then. And so there was like 10 of us in the class, and we did a 3-year program. We graduated in 2006. I graduated with a master's from there. And I've been practicing for 10 years now as a nurse practitioner with a local nephrologist.
Okay, very good. How do you establish relationships with your other healthcare professionals in your field? As far as you work right now with a nephrologist, so with them.
I guess it's a collaborative relationship.
Okay.
As nurse practitioners in the state of Texas, we're not directly supervised by physicians. We have a collaborative relationship, so they just basically have to check our work, 10% of our charts, and we don't have to work under them per se. We can open our own clinics. Of course, billing is a little different. We don't bill at 100%, but if the physician's on the site or in site, we could. So it's a very different relationship than maybe like a physician assistant who is held to different standards or different rules. So I have a very open relationship with this physician. He pretty much trusts me. He trained me himself right out of NP school. I was with him for a year. I left him for about 3 years because I had to explore my options, and I did come back, and like I said, I've been with him for 10 years. He's a phone call away. I can just call him, and he knows that I'm not calling him every day. I will call him maybe 3-4 times a year, because I've become very, I guess, versed in nephrology. It's a specialty area, so you kind of see a lot of routine and a lot of repetitive care. But he's very receptive to us. I'm one of 2 nurse practitioners in his practice. In fact, most of the time, physicians come and go into his practice, but me and the other nurse practitioner have been kind of like the pillars there. We haven't left, so.
Faithful ones. Okay. In your experience, tell me how you would handle a disruptive physician in the workplace if you had to deal with somebody like that.
I think pretty much the same way you would handle any other person that's disruptive in the workplace. You obviously don't want a crowd, so if it's something that can maybe be taken to an office, a different room, somewhere away from the patients or the other staff, just basic respect. Everybody has gone through an education. They chose a medical track. I chose the nursing track. Basic respect, communication. A lot of times, issues that arise in any kind of workplace is because of lack of communication. And so I really believe that just talking it out can usually solve the problems, and the miscommunication can be figured out.
Okay. What are some of the barriers that you encounter while working with other healthcare professionals?
I think a lot of the barriers that I experienced was early on in my career. Nobody knew what a nurse practitioner was.
Okay.
Everybody just said, "Oh, so you're a physician assistant," and I have no. It's not an insult. It's really, we have the same degree. It's just 2 different trainees. I mean, they get trained under the medical model, and I've been trained under the nursing model. And so, but for me, it's like I worked really hard for my degree, and so I would love for people to know who I am and what I stand for. So a lot of the barriers where people here in the Valley didn't recognize it, nurse practitioners are nothing new. They've been around for at least 60, 70 years. But usually this was a training that was done up north. Everything takes a while for the Valley, to get to the Valley and for the Valley to get accustomed to. So when I graduated, like I said, in 2006, there was only like 10 of us. Now they graduate classes of 30, and people compete to get in. Usually we have 200-300 applicants. It's a very good career, but the barriers encountered at that time were the fact, again, nobody knew what my scope of practice was, what could I do, what I couldn't do. They just thought it was a glorified nurse, and so sometimes the pay was not there. The respect, sometimes it took a while to come from the physicians. Not my physician. My physician always knew where I stood, and he kind of gave me my place. But sometimes the biggest disrespect were from other physicians when they would tell their patients, "Oh, well, you're paying good money so you could be seen by the nephrologist, not by the nurse. You should demand that the nephrologist see you." And so it was like, well, you don't know the kind of care I give, so why would you judge me, for one? And once the patients got to know me, no offense to my physician, but they liked me more than the physician because we take a different approach. We kind of encompass family, economical status, financing, because what's the point of treating a patient and giving them a medication if you don't look into their social or financial aspect and you realize that they're homeless or maybe they don't have insurance, or the medication you're trying to give them, for as great as it can be, they can't afford it. And so we take a different aspect, or towards the nursing or the medical, the treatment, diagnosing. And so once they got to know me, I pretty much won them over. And you would see that the patients would be like, "Oh, well, I don't want to go with the doctor. I want to go with Nora," and because they call me Nora. And so I ended up winning them over. So, but it was just that initial thing that it's like, I understand that the physician was not educated himself, but why would you go and continue the ignorance and pass it on to the patient? Just let them figure it out themselves.
Okay. Would you, if needed, ask another healthcare provider's assistance regarding patient care?
Definitely. I mean, I'm not an island. I'm not a silo. I have to work with people. And that's not what nurse practitioners are about. we like the collaborative work. We want to be working with you, next to you. We don't want to be above you. A lot of times my physician's like, he goes, you know more than some of my new nephrologists. I said, I understand. He goes, you should have gone to medical school. And many a times a lot of my friends and my husband is like, you could have just been a doctor by then. Well, I am a doctor, and I have a doctorate in nursing. It's like, no, you know what I mean, a medical, an MD. That was not my passion. That's not what I wanted to do. If I wanted to be a doctor, I know I could have, but that wasn't my calling. So we all just kind of have to respect ourselves, and I guess the roles that we do have, because we all bring something to the table.
Okay. Tell me how you maintain the level of professionalism without compromising the organization you currently work for.
Pretty much the same way that I've carried out pretty much my whole life. Being honest, being approachable, having open communication, having that open door policy. You can come and ask me. Feel free to share things with me. I don't have the answers for as much as people think I do. I don't have the answers to everything, but we can problem solve and we can figure it out together. And if not, we'll bring somebody else in and we'll figure it out together. But yeah, I think.
Okay, this is regarding patients. So tell me how you establish relationship with your patients or your clients.
Like I said, I just ask them to give me a chance, and so most of the time, initially patients are a little reluctant to come with me. I speak very well, Spanish very well, and so that always helps here in the Valley. If you don't look Hispanic and you don't speak Spanish, sometimes there's a lot of barriers, and I've seen that from a lot of doctors that we've had coming in, and they're maybe Asian and they don't speak Spanish, or they're Anglo and whatever, and so the patient sometimes can be almost like a bully to them, because they're like, oh, well, they don't even speak Spanish, what are they doing here, don't they know where they're at? And you get into that whole, well, I've heard physicians say before, well, we live in America, they should speak English if they want me to treat them. Well, unfortunately, the area we're in, and it's a very large Spanish speaking area, and so you kind of have to assimilate down to that patient, because if not, then guess what? You're not gonna get paid. You're not gonna have patients. And so I guess being a female, I'm pretty approachable. I come in with a smile on my face, no matter how hard my day is going, and I listen to them, and I take the time to go over their labs and educate them and go over their medications and talk to them about whatever they have. So I take a different approach, and eventually, for the most part, I win them over. There are going to be some that say, no, you know what, I want a physician to see me. And I said, you know what, you have every right to. And so usually what I do for those patients, I'll say, you know what, let me get this assessment out of the way first, and then I'll bring in the doctor so he can come and see you. And they're usually pretty happy about that as well. So.
What are some of the barriers you encounter with your patients? I mean, you mentioned some already, but are there any others? I know the language barrier.
The language, obviously, my patients, being nephrology, they're a lot older. So their customs and their habits are different. Also, they tend to have limited resources, because either they're retired or they're just, living off Medicare, Social Security. Sometimes, they don't have the money to pay for their medications, or, they can have Medicare, but they don't have the Part D for their medications. So a lot of issues with funding. We also have a lot of the people who are here maybe illegally or have never been able to hold a job here, and so the indigent care. We have a lot of patients that need dialysis and should be getting dialysis, but because they're not U.S. citizens and they've never contributed to the system, they don't qualify for it. So you feel bad because in America, and if you've contributed to the system and let's say you end up on dialysis, you'll get disabled, you'll get your benefits, and you get to receive dialysis in an outpatient setting in a clinic 3 times a day. Each treatment's about $10,000, so it's a $30,000 treatment.
3 times a day.
Well, I'm sorry, 3 3 times a week. I'm sorry, I said that wrong. 3 times a week for about 4 hours, but each treatment's about $10,000. But you get to have, a clinic where you can go 3 times a week. If you are on the opposite spectrum and you don't have insurance, you're not a U.S. citizen, you cannot go to one of those private clinics or outpatient clinics. So what you end up in the ER once a week. They have to do an assessment. They look at you. They do your labs. If your labs are critical and then they deem you to need dialysis, then you get emergency dialysis. And so they put in a catheter. They do a dialysis. Then they pull the catheter, and then they send you on your way home. And you do this week after week.
Leave the catheter in.
No, they take it out, because if they leave a catheter, then they have an access for, it's like leaving a patient with an IV.
Mm-hmm.
You can't have an open access. So I think about that, and those poor people, and if they come in, they feel sick. No, well, your labs are not critical enough, so you don't get dialysis today. So they keep coming in day after day, week after week. That is their life. Mm-hmm. And then if, the other side of the coin is if they were to go back to Mexico, well, Mexico, it's all payment first, and so they wouldn't even get that part of it. They wouldn't even get dialyzed emergency room style or outpatient. They would just end up dying on the street somewhere. So it's a hard life. So you have to kind of see what you can do to pay for patients within the limits, within their financial status, of course.
Okay. It's kind of like a big puzzle.
Yes.
Tell me how you establish trust with your patients and create that great patient experience. And then you mentioned it already. So,
basically just being honest with them, explaining all their risks and benefits, making sure that they understand their medications, why it's important. Sometimes, they label people as non-compliant, and it's not because they don't want to be compliant. It's, again, we go to the same thing. They don't have the money. They don't have the resources. Maybe they don't have light, and you're telling them that they, need to be able to take these things 3 times a day. Well, they don't have electricity in their home. They don't have, running water. They can't keep anything sanitary. And so you kind of have to figure out where they're at. And so just by being honest and telling them, if you just give them the knowledge, then they're not non-compliant. A lot of times it's not non-compliance. There's some patients just don't care, and they're not going to do it no matter how many times you tell them. But a lot of the times I've noticed that the people that they label as non-compliant, they're just knowledge deficit. They just didn't know why. Nobody ever bothered. They just said, take it. And it's like, okay, well, nobody likes to be told just to do something.
Nobody explained
Nobody explained why. Why do you have to take it? If you don't take it, this happens, and you end up here. So, obviously, they don't want to end up in the hospital, but so it's just a knowledge deficit, I think.
Okay. And then the last one, how would you handle a patient who refuses care? Just completely refuse care.
In the nephrology part of it, it's really hard, because if they refuse to go on dialysis, it's pretty much a death sentence for them, because your body needs to be cleaned. It needs to have all the toxins removed, all the fluid, and so if they choose not to do this, it's impending death, pretty much. It might not happen in a day or two, but eventually they get toxic enough to where they're, they start getting, yes, exactly, they start damaging their vision, their mental status starts changing, they can stop breathing, fluid backs up into the lungs, they start aspirating, and so it's a slow and painful death if you think about it. So I try to bring in the family whenever a diagnosis like this is going to be given, and I have to tell patients, you know what, your kidney function has dropped below 10%, and so this is a time I need to start prepping you for dialysis. And of course, you have to explain the access for the arm, what they'll have to go through for the rest of their life unless they get a transplant. And so you start doing all this, and usually what I do is I ask them to bring in family members. If it's a mom, I tell her, bring in your husband, bring in your children, because you want them all to know where this stands. Of course, within the scope of patient confidentiality, if she allows it. If she doesn't, of course, then, my hands are tied, but I document everything. And so if you bring in the family and you start, of course, you bring in the children and stuff, sometimes that helps encourage the patient. Dialysis is not a death sentence because you can live a very good, healthy life for as long as you follow the treatments. And then sometimes in the process of all that, a family member will say, you know what, let me go get tested, and they end up doing a living donor. So they give a kidney to their loved one because they don't want to see them on dialysis. Or they get on a transplant list and they can get a kidney that way. So a lot of times they don't have to be on dialysis forever. But, you know, it's like anything. It's like being given a cancer diagnosis or anything. It's hard initially. You need to let the shock kind of like wear off, and then you start giving them more and more information. So.
Okay. Once you have informed consent, or consent from a patient that they no longer want to have care, then you have to honor that.
Yes, definitely. So if they do like a do not resuscitate or refusal of treatment, then you have to honor that. Unless the patient, then you get into the legalities of maybe they're deemed incompetent, mentally incompetent, and or there's somebody who is their legal like a surrogate, exactly, where they can make medical decisions for them, and then it goes to them. But technically, yes, a patient, for as long as they're in legal mind and body, yeah, we have to honor them.
Okay. Even though you know that they can live.
Yes, of course, and you try, and then sometimes the patients know, and if you start prepping them, I mean, you don't have to tell them when they have 50% function, but you just keep prepping them, and you start little by little telling them, you know, what could happen, where this needs to go. Usually it doesn't hit them as hard. It's the harder ones are the ones that maybe get referred to us like maybe 3 months prior, and then they're already coming in with a function of like 15%. Okay. At 10%, we need to start putting them on dialysis, and so we have 5% to work with, and so those are the cases that are kind of harder to explain, and the patients, of course, accuse you of saying, well, you just want to make money out of me. You just want to connect me. There's nothing wrong. Why didn't my doctor tell me? And so they start going through the whole kind of grieving process, you know, no, it's not me. And then, why me? And then they start accepting it. So they get angry, and understandably so, because, I mean, this did not happen overnight. Right. But sometimes, you know, physicians don't refer them out quick enough and stuff, or their medical conditions like diabetes, hypertension just kind of accelerate the damage, and their lifestyle, you just never know their lifestyle.
Okay. Well, I want to thank you, Dr. Martinez, for letting me interview you, and I appreciate it. That is it for our interview, and I want to thank Dr. Martinez again for letting me interview you. Thank you.
You're welcome. Thank you.
Cut. Let me see what it's